Good morning, doctor. Yeah, like if you could able to hear me, please do let me know. And if the screen is visible, all right. So, yeah, fine then, fine. All right, doctors, let's begin. So let's take up, few questions which has been, confusing people that was asked in, previous INI-CET papers as well. Questions that has good amount of concepts and that was pretty bit confusing. So let's take up the very first question. First one, what causes detachment of myosin head from actin during muscle contraction and relaxation process? Now, guys, could you able to bring out with an answer? What causes detachment of myosin head from actin during muscle contraction and relaxation process? A, breakdown of ATP, B, Cerca pump, C, mitochondrial activity, D, titin and nebulin. Any guesses? All right. A, breakdown of ATP. Okay, breakdown of ATP. All right, people. Fine. All right. Let's get to the answer here. Now, the right answer for the question is C, mitochondrial activity. First thing first, let's understand why this is the right option and why not other options are right. And then let's get to understand the question and options as well. See, people, the question emphasizes the process of detachment of myosin head from actin. So the process of detachment is essentially all about relaxation. So we are not focusing on the contraction process, where this question is all about how a muscle relaxes, right? Now, when it comes to breakdown of ATP, please remember this. ATP breakdown is going to give you energy, right? ATP is going to be broken down to adenosine diphosphate plus a molecule of phosphate plus liberation of energy. And this liberation of energy is going to facilitate contraction process and not relaxation. The liberation of energy is going to power contraction and not relaxation. So option A is wrong. Option B, Cerca pump. Of course, Cerca pump is going to pump calcium into the sarcoplasmic reticulum. This definitely will cause relaxation. This will definitely cause relaxation, but this relaxation is not going to be because of detachment of myosin head. The detachment process will not take place. It's going to be a simple relaxation alone, guys. So without detachment, the relaxation takes place. So hence it is not the right answer. Mitochondrial activity. Mitochondria is going to generate adenosine triphosphate. There is going to be generation of adenosine triphosphate. With generation of adenosine triphosphate, there is going to be relaxation. So what you need to understand here is relaxation is brought about by generation of ATP. Relaxation is brought about by generation of ATP and not breakdown of ATP, doctors. Please remember. All right, breakdown of ATP is not going to contribute to relaxation. It will power contraction. Titin and nebulin has got no role in both contraction as well as relaxation. They have absolutely no role in both contraction and relaxation. So out of the options given, the best option that fits for relaxation by separating actin and myosin, all right? Relaxation by separating actin and myosin is going to be one and only option C, mitochondrial activity. So let's get to see what exactly happens there, doctors. please understand, when it comes to muscle contraction, let me start with the process of muscle contraction, which means if you see a muscle in a relaxed state, the head of myosin will be in a more flat orientation. Please remember, we are going to have a thin filament made of actin, and to this thin filament, if you look at the thick filament, the head of myosin will be in a flat orientation, and the head of myosin is seen attached with a full molecule of adenosine triphosphate. This is the configuration of relaxed state. Whenever there is going to be release of energy from this ATP, when this ATP breaks down to adenosine diphosphate, still a molecule of phosphate is attached. There is going to be partial energy available. This partial energy will make the head of myosin to go and bind with thin filament. Still, there is not going to be contraction. It's a simple attachment, that is all. Tail of myosin, neck of myosin, and head of myosin. Please remember, doctors, this is not contraction yet. So at this position, the head of myosin is seen attached with adenosine diphosphate plus the molecule of phosphate. Because the phosphate is still attached with myosin head, the available energy is not going to be complete, rather it is going to be partial energy. Now, when and how contraction is going to take place? The phosphate molecule is going to be taken away from myosin head. And let me take you to the next orientation. Here the adenosine diphosphate plus a molecule of phosphate is going to be getting converted to simply adenosine diphosphate alone, because the phosphate is completely taken off. In this position, what happens is the tail of myosin is going to be like this, neck of myosin is going to be like this, and head of myosin is going to be like this. In this configuration, people, there is going to be simply adenosine diphosphate alone, and at this position, the thin filament is getting pulled in. The thin filament is getting pulled in, doctors. This is one striking event that's going to happen to myosin chain. So with complete detachment of phosphate, when phosphate is completely detached, all right, the original attached phosphate molecule is now completely detached. When this complete detachment of phosphate takes place, there is going to be maximum energy availability. And in this maximum energy state, the head of myosin, please remember, this is most important, the head of myosin is going to bend towards M line. There is going to be flexion of myosin head, and this flexion takes place toward M line. As a consequence, the thin filament is pulled in, doctors. As a consequence, the thin filament is pulled in towards the M line. So you can clearly see when the muscle is in a relaxed state, the head of myosin is attached with adenosine triphosphate. When a muscle is in a relaxed state, the head of myosin is seen attached with adenosine triphosphate. During the process of contraction, adenosine triphosphate breaks down into ADP and phosphate. And once the phosphate is completely detached from myosin head, there is going to be maximum energy availability. Only when maximum energy is available, there is going to be flexion of myosin head towards M line. And this flexion towards M line is what is called as power stroke. So for power stroke to happen, which is the significant part of contraction, we require adenosine diphosphate completely breaking down into adenosine diphosphate and a molecule of phosphate, and that molecule of phosphate is thrown away. This is contraction. And if you see the option, we see that breakdown of ATP is going to be option A. So when ATP gets broken down, we are going to see contraction process and not relaxation process. So that's first and foremost point, doctors, you need to understand. When it comes to relaxation, how does a muscle relaxes? Of course, relaxation is significantly dependent on ATP. So the first and foremost event is mitochondria has to keep generate. Mitochondria has to keep generate adenosine triphosphate. The adenosine triphosphate coming out of mitochondria is going to act on two different sides. Number one, the adenosine triphosphate is going to power SERCA pump, sarcoplasmic endoplasmic reticulum, calcium ATPase pump. SERCA pump is going to pump calcium from the cytoplasm into the sarcoplasmic reticulum. As a consequence, cytoplasmic calcium level drops. And this leads to profound relaxation because you need calcium to be attached with troponin C. Because SERCA pump takes all the calcium into the sarcoplasmic reticulum. All right, the available calcium in the cytoplasm drops. As a consequence, the muscle goes for relaxation. So that's how SERCA pump generates more intra-sarcoplasmic reticular calcium, leading to relaxation of muscles. Number two, the same adenosine triphosphate is going to bind with myosin head. When adenosine triphosphate binds to myosin head, you can understand that the head of myosin takes up a flat orientation. In this flat configuration, the head of myosin is going to stay away from actin. When myosin detaches itself and stays away from actin, this leads to relaxation of muscles. So for muscle relaxation to take place, what is needed? Adenosine triphosphate. The full molecule of adenosine triphosphate is needed, which comes from mitochondria. So when mitochondria works, when mitochondria acts a lot, mitochondria is going to generate ATP. As a consequence, we are going to see relaxation of muscle. Remember this, relaxation of muscle is going to take place. So that's muscle relaxation. And this is the reason why mitochondrial activity is going to be the best answer for the question. What causes detachment of myosin head from actin? It requires a full molecule of adenosine triphosphate. All right, people. So mitochondrial activity is going to be the best answer for this question. And if this doesn't take place, when mitochondria do not produce ATP, for example, oxidative phosphorylation is not happening in mitochondria. What can happen? Because there is no oxidative phosphorylation, there is not going to be ATP synthesis. When ATP synthesis doesn't take place in mitochondria, there is no SERCA pump activity, there is no detachment of myosin head from actin. As a consequence, actin and myosin stay connected persistently. When this connection happens persistently, this is going to be called as rigor mortis. You know that, right? After death, mitochondria do not synthesize ATP. As a consequence, the muscles remains contracted. There is not going to be any relaxation. So failure of muscle relaxation after death is what is going to be called as rigor mortis. So please understand, the clinical applied aspect is going to be rigor mortis. So guys, I hope you understand why option C is the right answer for this question. Any doubts in the first question, doctors? Shall we move on to the next question, guys? Are you clear with the first question? All right, very good. So now let's move on to the second question here. Neurons involved in gate control mechanism of pain. All right, neurons involved in gate control mechanism of pain. A alpha, A beta, C interneurons. Any guesses? Any answers, doctors? Very good. A alpha or A beta? Good, Dr. Srikanth. You're right. It's A alpha. Option A is the right answer here. A alpha is the right answer. Let's get to see why A alpha neuron is the right answer, people. Let's understand gate control theory. So what happens in spinal cord? Now, let me take up two neurons. So there is a site of inflammation. And from this inflammation, we are going to have type C neurons, unmyelinated type C neurons, carrying the action potentials all the way to the pseudounipolar neuron in the spinal cord. So let's take this as spinal cord, doctors. In the spinal cord, we are going to see type C neurons, unmyelinated type C neurons. From this, we are going to see onset of dorsal column pathway all the way to brain. Sensory cortex. We'll keep the black one as sensory cortex. And within the spinal cord, we're also going to see another neuron. And this is going to be an interneuron, doctors. And this interneuron is going to block the postsynaptic neuron. Let me take up an interneuron. And this interneuron is going to inhibit the postsynaptic neuron here. This is a small, very small interneuron. And this interneuron is located within the spinal cord. And the job of the interneuron is going to suppress the second order neuron that starts from spinal cord all the way to brain. This interneuron is in turn getting excited by another neuron. And this is going to be, this neuron is going to be A beta neuron, doctors. This is going to be A beta neuron. And this A beta neuron is very well myelinated. You can clearly see this A beta neuron is very well myelinated. This is again another pseudounipolar neuron. So again, another pseudounipolar neuron is going to involve in exciting this interneuron. That's very important point, exciting interneuron. And you guys know very well, A beta neurons carries. What are the stimulus carried by A beta neurons? A beta neurons carries touch, pressure, as well as vibration. Touch, pressure, as well as vibration. So what exactly happens? Say, for example, if a subject goes through a serious kind of, painful sensations, in order to relieve the subject from experiencing this pain, what we do is, we will be applying massages, we'll be applying liniments, acupuncture, acupressure, these kinds of techniques. These, massages, the application of any heat liniments, ointments and everything. These kinds of methods will go and excite A beta neurons essentially. So by applying touch, by applying pressure, by applying vibrations, we are practically stimulating A beta neurons. When A beta neurons are getting stimulated, impulses travels via A beta neurons. These impulses go and activate interneurons. Once interneuron gets activated, you know what will happen. The interneuron will go and block the neuronal transmission from the spinal cord. Since the neuronal transmission from the spinal cord is not happening, since this neuronal transmission is not happening, this will ultimately result in no transmission of action potentials to the brain. As a consequence, sensory cortex do not get the action potentials from the pain conducting fibers. So even though the pathophysiology is still there, the insult is still there, the pain perception is going to be absent. And the reason for absence of pain perception is no excitation taking place in the postsynaptic neuron. So the neurons which are involved in gate control mechanism of pain is going to be interneurons. You know this? C neurons. Type C neurons are the one which is actually carrying the pain sensations. And A beta neurons are the one that is going to block the type C neuronal conduction. So all these three neurons are actually involved in gate control mechanism except A alpha neurons. Why A alpha neuron is not involved? Because A alpha neuron is essentially involved in very rapid touch as well as proprioception. These rapid touch and proprioception is not going to participate in gate control theory. As a consequence, A alpha is not actually involved in gate control theory, doctors. If the question is asked in another way, instead of giving A alpha, if the nerve fibers have been classified by numerical method of classification, please remember this A alpha is also classified as 1A fiber as well as 1B fiber, while A beta neurons are classified as type 2 neurons. A beta neurons are synonymously called as type 2 neurons. All right, just remember that. All right, people. Now, when it comes to gate control theory, you need to be very familiar, the logic, basics, everything. So what are all the methods with which we are going to use these gate control theory, and we take the patient's pain off? We make the patient to stay free from the pain. It is essentially done by massages, acupuncture, acupressure, as well as a method called as TENS. Very important. TENS. The exact word has been asked in May 2022 INI-CET exam. So what do you mean by TENS? TENS stands for transcutaneous electrical nerve stimulation. Transcutaneous electrical nerve stimulation. We are going to apply some electrodes to the skin. Through the electrodes, we are going to send current impulses, and these current impulses are going to stimulate the nerves, especially A beta nerves. All right. So transcutaneous electrical nerve stimulation is what is called as TENS, doctors. So this patient will experience a kind of vibration in their body, and this vibration is going to transmitted through A beta neurons, and this vibration go and activate interneurons. Once interneuron gets activated, there is going to be an inhibition of transmission from the postsynaptic neuron that is supposed to carry the painful sensation to the brain. That's gate control theory, doctors. Guys, have you understood this? If you understood gate control theory and there is no doubts in gate control, we can move on to the next question. Guys, you got gate control theory? Next one. Yeah, very good. Very good. So let's move on to the third question. Countercurrent mechanism. Countercurrent mechanism is seen in all structures except option A, testis, B, kidney, C, skin, D, lungs. Now, any idea what could be the answer? It's a straightforward question. I think you can able to answer this quite easy. The structure which does not have countercurrent mechanism. People, it's a simple question anyway. The right answer for the question is going to be option D. Very good, Dr. Srikanth. Very good. It's going to be option D. Lungs does not have countercurrent mechanism. Get to know what is countercurrent mechanism first so that you don't get it confused. You need a parallel blood flow. That is all. That is all, doctors. We need a parallel blood flow. So the arterial blood flow and venous blood flows are going to be so very close. So let me take up a arteriolar blood flow that happens in one direction. And let's take up venous blood flow. That happens in other direction. So this is the basic logic behind a countercurrent blood flow, doctors. Why is this important and why countercurrent mechanism is so crucial? Now, first point, countercurrent mechanism is operating in a manner that the molecules on one blood vessel, rather than traveling to the end of the blood vessel, will be immediately transported to the neighboring blood vessel. That is all. So a molecule doesn't has to be reaching the end and then it doesn't have to come back. Rather, there is going to be a quick transfer of molecule between two blood vessels. This is one of a very, very important key principle behind countercurrent mechanism. And that transfer can be anything. What is essentially getting transferred? The most important transfer going to be transfer of oxygen. The second one is going to be transfer of temperature. And the third one is going to be transfer of solutes and water. You can clearly understand the transfer of solutes and water takes place in kidneys. The transfer of oxygen takes place in testes as well as gastrointestinal tract, and transfer of temperature takes place in skin. So what exactly happens when it comes to oxygen transfer in testes and gastrointestinal tract, doctors? So if you consider these parallel flow of blood in these blood vessels, let's understand this, what happens when it comes to testis as well as GIT. In testis and GIT, what happens is, see, when it comes to the terminal capillaries, arterioles, you guys know this, arterioles brings about a network of capillaries, and these capillaries joins to form venules, and these venules ultimately joins to form veins. Now, it is the tip of the capillary which is going to perfuse a enterocyte. The enterocytes are going to be perfused by tip of the capillaries, doctors. All right. Now, what happens is when the arteriolar blood carries oxygen, because of the very, very, very close proximity of arteriolar vessels and venular vessels, number one. Number two, the enterocyte is going to be taking up a lot of oxygen because of its enormous metabolism. So whatever oxygen that comes to the capillaries will be immediately grabbed by the enterocytes. As a consequence, the venous blood will have very little oxygen in venous blood. So the oxygen in the arterial circulation doesn't completely reaches the capillary. Before even it does, because of the very less oxygen in the venous blood, good amount of oxygen is getting transported to the neighboring venular blood vessels. So oxygen does not completely reach the capillary. Before doing so, good amount of oxygen gets transported to the venular blood. What's going to be the consequence? Because of this manifestation taking place, the terminal part of the cells, especially enterocytes, will always receive less oxygen. These enterocytes will be receiving very little amount of oxygen, doctors. As a consequence, these kinds of cells and enterocytes are vulnerable for hypoxic damage. Even when there is a slightest drop in oxygen supply to the enterocyte will cease its function. There will be destruction of enterocytes. Why? Because in normal healthy condition itself, the amount of oxygen taken up by the enterocyte is going to be very, very, very less. You guys know, if a patient experiences shock and if a patient recovers from shock, it's inevitable that a patient will experience, mesenteric ischemia. As a consequence, there is going to be loss of enterocytes, right? This is so severe in the sense because in natural physiological condition itself, the amount of oxygen that is getting supplied or delivered to the enterocyte is going to be very less. And this hypoxic state will be worsened in shock, which is why there is going to be mesenteric ischemia and intestinal necrosis that can happen with shock doctors. That's what happens in gastrointestinal tract. When it comes to testis, as well as when it comes to skin, 2 points you need to understand. Testis uses the countercurrent mechanism for two purposes. Number one, the oxygen supply. Number two, temperature dissipation. Now, let us consider the testis in terms of oxygen supply. Because the arteriolar vessels and venular vessels are so very close, let me, I'll tell you the purpose of the proximity of these two vessels in a moment's time, but as of now, understand these two vessels are very closely located. As a consequence, the oxygen that is getting delivered to the developing spermatozoas and the Sertoli cells and Leydig cells, these cells don't get complete oxygen because good amount of oxygen is going to be transferred to the neighboring blood vessels. So again, whenever there is going to be hypoxia, the genesis of spermatozoas from Sertoli cells are going to become compromised. The reason is, the prime reason why a testis do have this countercurrent blood flows, it's going to be the same reason why skin do have countercurrent blood flow, and this is because of temperature dissipation. This is because of temperature regulation. When I say temperature regulation, it's nothing but heat dissipation, doctors. Heat dissipation. Testis as well as GIT uses countercurrent blood flow for oxygen transport. There is already a comparatively decreased oxygen supply. And skin and testis shares this countercurrent mechanism for heat dissipation. Reason is, we can't afford to have more amount of heat in the testicular region because you guys know excessive heat or increased body temperature will impair gonadogenesis, all right, will impair gametogenesis from the gonads. So if a patient experiences more temperature, the temperature is going to impair the spermatogenesis process, which is why the temperature has to be maintained in a comparatively cooler environment, for which we need the temperature to be dissipated off. All right, there must be convection of heat out of the body. How does this take place? The blood that comes from the central circulation carries the heat, and when the blood reaches the capillaries, the heat will be dissipated, and the blood that returns back into the venular blood will be coming out with very less temperature. So on one side, we are going to see a blood that's going to be flowing with a greater temperature. On the other side, we are going to see a blood that is going to flow with lesser temperature. When the temperature of blood in the other vessel is very less, there is going to be transfer of heat from one blood vessel to the neighboring blood vessel. So before even the heat is dissipated to the periphery, good amount of heat is transported to the blood of neighboring blood vessel. As a consequence, there is going to be early dissipation of heat. When the heat in the blood vessel is getting dissipated early, of course, not to the periphery, but to the neighboring blood vessel, the temperature of blood in this vessel is going to be very much decreased. As a consequence, the heat will be transported or transmitted from the central circulation to the peripheral circulation. So that is how the temperature from the core of the body will be acutely reduced, but the disadvantages, it is not getting thrown out to the skin and exterior, rather it is getting dissipated to the neighboring blood vessel. So these are all the purpose of countercurrent mechanism happening in testis, GAT and skin. So guys, we do see countercurrent mechanism taking place in testis, kidneys, GAT and skin. GAT and skin. All these sites do have countercurrent mechanism. It is not present in lungs alone. So lungs is the best answer for the question. Countercurrent mechanism is seen in all the structures except, and the answer is going to be lungs, doctors. Fine. Yeah, let's take up the next question. Again, something quite important. Guys, could you able to get the answer for the question, people? Any guesses? There is a vasodilatation, and the question asks how much time the flow changes. That's the question here, doctors. All right. So very good, Dr. Mohan. Beautiful. Good. Very good. 16 is the right answer. Very good. So let's take up this question. We have a blood vessel here. And this blood vessel is normal. And we have blood flow happening in this vessel. After a drug has been administered, the diameter of the blood vessel is increased. That's what the question says. The diameter of the blood vessel increases from the original diameter of 1D all the way to an increased diameter of 2D, doctors. It's going to be 2D. Now, how are we going to calculate the flow? To calculate flow, we got to consider two formulas. The first one is going to be a variant of Ohm's law. First one is going to be variant of Ohm's law that says flow in a vessel is directly proportional to pressure gradient. It's directly proportional to pressure gradient, and it is inversely related to resistance. That's Ohm's law. The second law we got to take into consideration is going to be Poiseuille-Hagen's law. So as per Poiseuille-Hagen's law, we are going to calculate resistance. Resistance is proportional to viscosity. Resistance is directly proportional to length of blood vessels. And resistance is inversely related to fourth power of radius. It is inversely related to fourth power of radius, doctors. All right, that's very important. Now, please remember, when it comes to such a kind of Poiseuille-Hagen's law, this is a law that has been, advocated for a cylinder that has got, a perfect Newtonian fluid flowing inside the cylinder. When it comes to human body, blood vessels are not perfect cylinder, and blood is not a perfect Newtonian fluid. Hence, the meaning is going to be staying the same, but the term, the name of the certain parameters is going to be changed. Please remember, because it is not a perfect cylinder, a blood vessel is not a perfect cylinder, and blood not being a perfect Newtonian fluid, when it comes to diameter, the word diameter or the word radius, they mean one and the same, and they are talking about the luminal caliber, that is all. They are talking about luminal caliber. And please remember, we are going to speak about the size of the lumen, that is all. All right. How much is the luminal size? Is it going to be small or is it going to be very big? We are going to talk about the luminal size alone. This has got nothing to do with the literal meaning of diameter or radius. People, do not confuse between diameter and radius. Don't think diameter is equal to 2 into radius and all, nothing. So when it comes to these kinds of Poiseuille-Hagen's law, I repeat, they all take up same meaning. Diameter equal radii, they simply mean luminal caliber, that is all. So if we substitute all these parameters in this question, we are seeing that the radius has been increased to 2 times, right? There is going to be increase in radius to 2 times. So what's going to happen? So the resistance is going to be inversely related to radius, isn't it? So it's going to be 2 to the power of 4, 2 to the power of 4, which is nothing but 16s. All right. So 2 into 2, 2 into 2. So 4 into 4, it's going to be 16 diopters. So actually resistance falls by 16 times. You see this. Resistance is inversely related to radius. So resistance falls by 16 times. Because resistance falls by 16 times, flow increases by 16 times. Flow increases by 16 times. So before the drug is getting administered, we'll consider that as well. Before the drug is getting administered, it's going to be 1 to the power of 4. 1 time is the radius. So 1 to the power of 4, it's nothing but 1. So the resistance is 1 time, the flow is 1 time. But with the administration of verapamil, there is going to be dilatation of blood vessel. The radius increases by 2 times. So the resistance drops by 16 times. And hence 16 times is the right answer for this question, guys. It's the right answer for the question. Brilliant. Very good, Dr. Mohan. Good. So that's the question. We'll take up the next question, people. The following change is seen in high altitude. What change are we going to see in high altitude? Any guesses, any idea? Something is seen at high altitude, people. Quick guess, guys. Very good. Very good, Dr. Srikanth. Pulmonary vasoconstriction is the right answer. Good. Good. Now, why pulmonary vasoconstriction and why not other things? When it comes to high altitude, first thing first, people, there is going to be hypoxia. Now, because of hypoxia, there will be alveolar drop in oxygen, alveolar PaO2. Partial pressure of alveolar oxygen is going to be significantly reduced. When alveolar oxygen is going to be less, this will lead to constriction of pulmonary capillaries. This is specifically called as hypoxic pulmonary vasoconstriction. It's going to be called as hypoxic pulmonary vasoconstriction. So definitely option A is the correct answer in a pulmonary vasoconstriction. What happens to oxygen hemoglobin dissociation curve? People, this is quite important. See, whenever there is going to be hypoxia, as a consequence of decrease in partial pressure of oxygen, there is going to be right shift of curve. There is going to be right shift of curve. On the other hand, because there is going to be, hypoxia, and this hypoxia will also lead to hyperventilation. Hypoxia will also lead to hyperventilation. This hyperventilation will lead to respiratory alkalosis. There is going to be carbon dioxide washout. I repeat this, because of hyperventilation, there is going to be carbon dioxide washout, and this will cause respiratory alkalosis. Whenever blood pH becomes alkalotic, this will cause left shift of curve. So one event shifts the curve to right, another event shifts the curve to left. But again, in hypoxic environment, because of apparent anemia, there is going to be increased production of 2,3 bisphosphoglycerate. Increased production of 2,3 bisphosphoglycerate. This is again going to shift the curve to right. So two factors shifts the curve to right, and just one factor shifts the curve to left. So because of dual effect, the curve will get ultimately shifted to right, doctors. And please remember, the net effect is going to be right shift of curve. Never forget this. Is it going to be only a right shift? No. There is one factor that will cause the curve to shift to left, and that is nothing but alkalosis, increased pH. All right. But the net effect is going to be right shift of curve. So B is not going to be the right answer. It's going to be right shift of curve. Anemia. Yes, the following changes seen at high altitude, there is going to be anemic environment. Only because of anemic environment, we do see two events. Number one, there is going to be increased production of 2,3 bis phosphoglycerate. Number two, there is going to be increase in erythropoietin production. Is this anemia real? Not exactly. It's going to be an apparent anemia. All right. There is going to be decreased oxygen supplied to the tissues, which mimics anemic state, which is why there is going to be increase to 2,3 BPG as well as erythropoietin production. All right, people. So please remember, this is a apparent anemia. This is a apparent anemia, and this is not a real anemia, doctors. And hence, we can exclude anemia as well. This is an apparent anemia. The subject is not going to lose RBC. The environment simulates anemia. There is no loss of RBCs. Number 4, increased cerebral blood flow. This is one tricky point you have to understand in clearer manner. So people, please remember this. In case of hypoxia, when this hypoxia goes to a level of arterial oxygen level of less than 50 millimeters of mercury, only at this level, we are going to see cerebral vasodilatation. Cerebral vasodilatation. But in a normal high altitude state, it will never ever go to this level, people, unless otherwise it is a very, very, very severe high altitude and the arterial oxygen tension becomes so profoundly reduced because alveolar oxygen itself is going to be so profoundly reduced. Please remember, this situation is seen in extremely high altitude, doctors. This is rare. This is seen in extremely high altitude, but this is rare. And there is a question in medicine as well. When the cerebral vasodilatation is so profound, this will even lead to a condition called as hypoxic, or in another way, high altitude. High altitude cerebral edema. HACE. The vasodilatation is so profound, this will even lead to cerebral edema, doctors. So this condition, cerebral vasodilatation leading to HACE, high altitude cerebral edema, are very, very, very rare. So even though increased cerebral blood flow is a possibility, we can't bring this to the right answer because it is going to be rare and pulmonary vasoconstriction is going to be very much common. All right, people, which is why we have chosen pulmonary vasoconstriction as the best answer for this question. And like the same way, high altitude cerebral edema because of cerebral vasodilatation, the hypoxic pulmonary vasoconstriction, if it becomes very severe, this will also leads to edema, and this is called as high altitude pulmonary edema. High altitude pulmonary edema, HAPE, but these two conditions are quite rare, guys. As a consequence, we don't usually consider, cerebral vasodilatation as the right answer as edemas, pulmonary edema or cerebral edema as the right answers. So please remember, since pulmonary vasoconstriction happens at every single subject who ascends to high altitude, and that happens universally for every single mountaineers or high altitude climbers, that's going to be the best answer for this question. Even though cerebral blood flow increases, it doesn't happen for everyone. It doesn't happen at every single high altitude. Usually there is going to be a hypoxia to a level of less than normal level, less than 98 millimeters of mercury, but it will rarely drop below 60 to the point of generation of cerebral edema. That's very, very, very rare, which is why we are picking vasoconstriction as the right answer, doctors. I hope you get this answer clear. Now, the next one is again an easy question. Central cyanosis is not caused by, which is not causing central cyanosis? Pulmonary AV fistula, high altitude, hypothermia, methemoglobinemia, guys. Any answers here which is not causing central cyanosis? Guys, all right. Fine. We'll take up the answer here. Pulmonary AV fistula as well as high altitude, they will be bringing down very much reduced oxygen in pulmonary veins. These two conditions, pulmonary AV fistula. In pulmonary AV fistula, there is going to be, mixing of oxygenated as well as deoxygenated blood. As a consequence, there is going to be reduction in oxygen tension in pulmonary vein. Similarly, in high altitude, there is hypoxia. As a consequence, there is going to be decreased oxygen in pulmonary veins. Methemoglobinemia. The hemoglobin does not bind with oxygen at all. Doesn't bind oxygen. As a consequence, there is going to be very much decreased oxygen in pulmonary veins. Because the three conditions decreases pulmonary vein oxygenation itself, there is going to be obviously central cyanosis. But hypothermia usually do not cause central cyanosis. If at all, there is going to be, exposure of very cold temperature leading to constriction of peripheral vasculatures. Peripheral vasoconstriction seen in skin. Peripheral vasoconstriction of skin, and this does not cause central cyanosis. Hypothermia will not cause central cyanosis, doctors. It's a simple peripheral vasoconstriction. That is all. It is not to the extent of causing central cyanosis. So there is no central cyanosis with hypothermia, and pulmonary AV fistula, high altitude methemoglobinemia definitely will cause central cyanosis, people. And the right answer for the question is actually C. It is not caused by hypothermia as the right answer. Hypothermia is the right answer, doctors. All right, that's central cyanosis, guys. Fine. A simple question. A molecule which undergoes secondary active transport. Which molecule undergoes secondary active transport among the options? Hydrogen, urea, amino acids, sodium. All right. Okay. Yeah, again, Dr. Mohan, this is something people tend to, often get it confused. Let's understand what is secondary active transport first, and then we'll get to the option. That will, give us a better clarity. Secondary active transport is something that involves sodium. Say, for example, I'll take a membrane, a phospholipid bilayer. I take this component as extracellular fluid and the other component as intracellular fluid. Now, let me take up a transporter here, and let this be sodium potassium ATPase. And you know that sodium potassium ATPase is going to pump 3 sodium out of the cell for exchange of 2 potassium into the cell. So there is going to be pumping of 3 sodium out of the cell. This is primary active transport. You know this. This kind of transport is primary active. Since sodium potassium ATPase continuously keeps working, it keeps on pumping 3 sodium out of the cell, doctors. There is going to be continuous activity of sodium potassium ATPase. There is going to be pumping of 3 sodium. So this is one of a very important reason why there is good amount of sodium in the extracellular fluid. There is too much of sodium in the extracellular fluid. Now, what is the gradient for sodium now? Since there is too much of sodium in the extracellular fluid and too little sodium in the intracellular fluid, there is a natural gradient for sodium to get into the cell. Please remember, sodium tries to get into the cell because of concentration gradient. Harvesting this power, what are we going to do? We are going to take up another transporter, which is going to take sodium into the cell. Please remember this, never ever forget. Sodium is going to be transported into the cell along the concentration gradient. Sodium is transported into the cell along the concentration gradient. This is not active transport. This is passive. All right. Because sodium, exclusively speaking, sodium is getting transported along the gradient. While this sodium transport is happening, using the same potential energy with which sodium is traveling, the channel also will let another ion to pass through. Now, this may be glucose. This may be glucose. Now, this transporter that transports sodium and glucose together is called the sodium-dependent glucose transporter. For example, I'm taking up, all right? This may be sodium-dependent glucose transporter or sodium-calcium exchanger. In whatever the scenario it is, there is always along the concentration gradient movement of sodium, there is always against concentration gradient movement of another ion. So the second ion is getting transported against concentration gradient, while sodium is getting transported along the concentration gradient. So sodium transport is passive. Sodium transport is passive, while the second ion that is moving is going to be transported in active method. Since only one ion is getting transported in active way and another ion is transported in passive way, we call this transport as secondary active transport. Since sodium is transported along the gradient, there is no ATP breakdown. There is no ATP breakdown. So doctors, when it comes to secondary active transport, please remember a secondary active transport is always dependent on. The secondary active transport is always dependent on. Always dependent on extracellular fluid sodium levels. And this extracellular fluid sodium levels is brought about by sodium potassium ATPase pump. It is brought about by sodium potassium ATPase pump, doctors. So that's secondary active transport. And please remember, in this question, you have hydrogen, urea, amino acid, and sodium. When it comes to hydrogen, usually hydrogen is transported by primary active transport. Rarely, hydrogen is getting transported by secondary active transport. Transported by secondary active transport. Coming to urea, the second molecule. Urea always getting transported by diffusions. And it's going to be facilitated diffusion. So obviously it is going to be a passive transport. It's going to be passive transport. Coming to amino acids. Amino acids also undergoes passive transport. Primarily, amino acids are getting, moved by passive transport. That is nothing but facilitated diffusion. Very rarely it is getting transported by secondary active transport as well. Only in kidneys. Only in kidneys, there is going to be sodium-dependent amino acid co-transport. Again, that's quite rare. And coming to sodium, you know this. Sodium is getting transported either by primary active, sodium potassium ATPase, or it is transported by passive transport that involves either of the case. All right, sodium can be transported in the secondary active transport, but still it is a passive mechanism, or we have sodium channels. We have sodium channels, all right? Ligand-gated sodium channel, voltage-gated sodium channels, whatever it is going to be passive. So the question is between just two molecules, whether this is hydrogen or is it going to be amino acids. Between hydrogen and amino acids, most of the time, hydrogen is getting transported by secondary active transport. To very, very, very rare instances, amino acids are getting transported by secondary active transport. Hence, the best answer for this question is going to be hydrogen. So people, the molecule which undergoes second reactive transport is going to be hydrogen, people. If it is not hydrogen, you can go for amino acids, but definitely it is not sodium. So the best answer is going to be hydrogen, and the second best answer is going to be amino acids. All right, that's the way the question has to be addressed and approached. All right, so I hope you understand why we picked the right answer, doctors. I hope you get the right answer for this question. Dr. Mohan, are you clear now? Yeah, that's good. Very good. Yeah. Fine. Let us take up the last question. Identify the condition best suited for the curve given below. Myoglobin, carboxyhemoglobin, fetal hemoglobin, methemoglobin. I'm sure you'd have, crossed this question many times in many discussions, but I just want you guys to be doubly confident and positive about this question. It's a November INI-CET 2022 question, doctors. Any idea? B, fetal hemoglobin. No, Dr. Srikanth, no. Yeah, since this is the last question, could you tell me why it is? Okay, it's myoglobin. All right, perfect. It's myoglobin. Good. It's not a fetal hemoglobin, it's myoglobin. Good. First thing first, this is obviously a left shift of curve. It's obviously a left shift. In that sense, myoglobin, fetal hemoglobin, carboxyhemoglobin as well as methemoglobin, everything can have the same kind of curve, left shift of curve. But the point you need to understand here is, let's start with myoglobin first. Myoglobin is a molecule which is made of only one globin chain. Rather than a conventional hemoglobin, where a conventional hemoglobin molecule is made of 4 heme with 4 ferrous atom. 4 ferrous atom, right? And these ferrous atoms are incorporated into heme rings, doctor. So there are 4 heme rings, and to each heme ring, there is going to be a globin chain attached. So there is going to be 2 alpha globin chain, and there is going to be 2 beta globin chains, 2 alpha and 2 beta globin chains, doctors. And you know the basic point, the affinity of oxygen